Good afternoon, everybody, and welcome to the webinar. Today, we are talking about different types of heart failure and how they need different types of care. I'm so excited to be able to share this presentation with you today. Before we get started and I introduce the speakers, I'd like to just give you a couple of quick updates to make your listening more enjoyable. All attendees are in listen-only mode. So if you have any questions, please use the Q&A box during the presentation. We will read the questions out loud if we have time for the presenters to answer the questions. Please note that the presenters will not be able to answer your questions for you if they're specific questions because they are not your treating physician. And then a recording of the presentation will be available following the event. It will be on our YouTube channel and on the website like we usually do. So the Mended Hearts Incorporated's mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. The Mended Little Hearts program serves the littlest heart patients of all, those who have congenital heart defects and their families. We also have a brand new program, Young Mended Hearts, which bridges the gap between Mended Little Hearts and Mended Hearts. I welcome all of you here today to learn about the topic. I am Andrea Baer, the Executive Director here at Mended Hearts. And without further ado, I'm going to go ahead and get started by introducing our speakers. First, the disclosures. Doctors Schumacher and Glass are employees of Pfizer Incorporated. Statements made during this presentation are those of the presenter alone and may not represent their official position with Pfizer Incorporated with respect to any of the topics discussed. Our first presenter will be Dr. Jennifer Schumacher. Jennifer received her PhD in pharmacology from the University of Minnesota, Minneapolis, USA, and a BS in biotechnology and chemistry from St. Cloud State University in St. Cloud, USA. With over 16 years of medical affairs experience previously at AstraZeneca Pharmaceuticals before joining Pfizer in 2010. She's held positions as a director of medical affairs in oncology, cardiology, neuroscience, and rare disease. Currently, Senior Global Medical Director in Rare Cardiology, supporting ATTR amyloidosis research and chair of the Scientific Publications Committee. Following her presentation, Dr. Oliver Glass will speak. He has received his PhD in pathology and MHS in clinical research from Duke University, Durham, North Carolina, and his BS in molecular genetics from the Ohio State University in Columbus, Ohio. Prior to joining Pfizer in 2021, as a category clinician in rare diseases, Oliver served as the Director of Research for Duke Health and Wellbeing and Assistant Professor of Medicine at Duke University from 2017 to 2021. Thank you both for being here. We really appreciate it. Jennifer, I'm going to turn everything over to you.
Thank you, Andrea. And is my camera on? I can't quite tell. I just wanted to see if it was turned on.
It is not.
Okay. Can I turn it on? It's okay if I can't. I was just going to.
Yes, I think you should be able to. I think Andrea is, will she be able to do that?
Yeah, she can.
Let's see here. I don't see it just because I'm in presentation mode. If I go out of presentation mode, can I do it or? All right. Well, I won't worry about it for right now. Unless you guys want me to make sure I have it on. Oh, there we go. There we go. There. Can you see me now?
Yes, we can see you. You look lovely.
Thank you. Thank you. Well, thank you, everyone. As Andrea very kindly introduced, my name is Jennifer Schumacher, and I work at Pfizer in their rare disease division. And I'm going to be talking about today, the name of the title is a little bit challenging because truthfully, what I'm going to be talking about today is one particular cause of heart failure that is a rare disease that has been historically very challenging for physicians to diagnose and to recognize. And oftentimes, many patients who end up being diagnosed with this type of heart failure have gone through many years of going to different specialists and different doctors, and it's really just taken too long for them to get diagnosed. So I really want to highlight for you a specific type of heart failure that, as we are learning more about it in the rare disease field, it has become much, much more prevalent than anybody actually really knew about historically up until about the last 5 to 10 years. So what you see on the slide is our agenda. And I'm going to talk to you a little bit about the disease background itself, how it manifests in patients and what patients' symptoms are and kind of the clinical manifestations that they experience. And then what doctors and patients need to do to help diagnose this disease accurately, and some of the tests that should be done and clues that help physicians as well as patients understand their disease a little bit more. So let me see if I can advance the next slide. Yes. So the disease that I'm going to be talking about today broadly is a disease called amyloidosis. There are multiple types of amyloidosis, and it can depend on, number one, what the precursor protein is that is responsible for causing the amyloidosis, as well as which organs are affected by that amyloid. So overall, amyloidosis is a disease where some protein, normal proteins in your body, becomes abnormal for some reason. It can misfold, it can have a mutation, it can be overproduced by the body. There's different reasons why some proteins will form amyloid, but these proteins come together into fibrils and become very difficult for the body to degrade and get rid of. And then they can get stuck and deposited in different organs. And when you get enough of this kind of sticky fibrous amyloid in different organs, it affects the ability of those organs to function properly. Now, today, what I will be talking about is an example of amyloid that gets into the heart and causes what we call cardiac amyloidosis. And ultimately, people develop heart failure because of all of the amyloid that is in their heart, which restricts the heart from working normally. So amyloidosis is a general term for a lot of different diseases. Cardiac amyloidosis is when those specific amyloid proteins build up in the heart. And we are really going to focus on one or two forms of this cardiac amyloidosis that causes heart failure today. So, oops, sorry about that. I just want to see. Yeah. So there are two proteins that are responsible for the vast majority of cases of cardiac amyloidosis. There is a protein called light chain. This is a part of antibodies. Antibodies are made up of light chains and heavy chains. Light chain amyloidosis is a disease where too much of that light chain protein gets produced by the plasma cells, and it forms amyloid and deposits in the heart. There is a very different and specific treatment for light chain amyloidosis, and it's well known about what light chain is generally, and it's treated by hematologists most often. The other most common form of cardiac amyloidosis is transthyretin cardiac amyloidosis. And this is really the focus of our talk today. Transthyretin is a normal protein that everybody has. It is a transport protein that transports two molecules. It transports thyroid hormones, thus the THY that's green, trans thy, and it transports retinol binding protein, or vitamin A. So it is a transport protein of thyroid hormones, retinol binding protein, and we have a nomenclature, or the way we name amyloid diseases is where we have an A in the front, and that stands for amyloid, and then the protein that's involved. So AL is amyloid light chain. ATTR is amyloid transthyretin. And so if you see this nomenclature, and we also call this cardiac amyloidosis or amyloid cardiomyopathy, it's the same thing. But these are the two proteins that are responsible for the vast majority of cardiac amyloidosis. There are some other proteins that are even more rare. Even though these are both rare, there are some proteins that are even more rare that can cause some cardiac disease, and those are listed below, but those will not be the focus of the talk today. So when we talk about transthyretin cardiac amyloidosis, or ATTR-CM, that is really what we're talking about today. So there are two subtypes of transthyretin cardiac amyloidosis. And the subtypes are really based on the amino acid sequence of the gene. And you don't have to be a geneticist really to understand this, but basically one type is called the wild type. There is no mutations in the gene. It is the normal transthyretin gene. But for some reason, as people age, it's related to aging, and we don't know the full mechanism. As people age, that normal wild-type transthyretin protein will form amyloid, and usually the main place it deposits is the heart. The other subtype of transthyretin cardiac amyloidosis is called hereditary TTR, or hereditary amyloidosis. This is the same exact protein, it's transthyretin, but people have a mutation in their gene, and that mutation makes the protein unstable. And the more unstable the protein is, the more ability it has to unfold, form amyloid, and deposit in different tissues and organs. Now, the wild type form is much more common than the hereditary form. The wild type form, which I'll talk a little bit more about later, also tends to mainly and mostly affect the heart, where the hereditary forms can actually affect lots of different organs, and really was identified originally in patients that had neuropathy and polyneuropathy. So they have a lot of issues, not only with their heart sometimes, but with other organs, and specifically with their nervous system. But we'll talk more about that in some coming slides. It's just important to know that if a person is diagnosed with ATTR cardiomyopathy, you should find out if it's wild type or hereditary, and there's implications obviously for family members if it is the hereditary form. So if we go to the next slide, now I'm going to move more into what does this disease do to the heart? What do patients experience? And what are some of the tests that physicians can do to help diagnose this disease? So amyloidosis in general, especially the amyloid that affects the heart, is a disease where the amyloid fibrils get in between the muscle cells of the heart. So the heart is a large muscle. It is made up of cardiomyocyte cells. When amyloid deposits in the heart, it doesn't go inside the cells necessarily. It squeezes in between each of the muscle cells, putting pressure and stress on all of the tissue of the heart. What happens when you get enough of this amyloid built up in your heart? The walls of the heart become thicker and thicker, and the heart becomes thicker and much more rigid and stiff. And this causes structural damage to the heart, which means it can't work as properly as it's normally meant to work. And a good example of what's happening, if you think about a balloon, and a balloon is kind of rubbery and pliable and flexible, and you blow it up with air and it expands and it contracts, and it's relatively easy to do this. And that's normally what the heart is kind of like, filling up with blood and contracting and ejecting the blood. When enough amyloid builds up in someone's heart, it becomes very stiff and rigid. And now that heart cannot relax, it cannot fill with blood like it normally is supposed to, and it cannot contract as well and eject as much blood out. So your hearts become, or a patient's heart would become very stiff and rigid, and it doesn't fill with enough blood to fill the body's needs. Now, one of the reasons this disease is challenging to diagnose is because the symptoms that people feel as they deposit amyloid in their heart are very similar to all of the other symptoms that people feel when they have heart failure due to other reasons. Other causes of heart failure can be coronary artery disease and diabetes and hypertension and much, much more common reasons and causes for heart failure, but the symptoms are the same. So there's nothing about the symptoms that a patient experiences that kind of triggers their physician to know that this is due to cardiac amyloid versus maybe something else like hypertension. So the symptoms that we were just talking about are shown here. They're very common to patients that do have heart failure. Many people experience a shortness of breath. They have coughing, and coughing especially at night, because the more your heart restricts, it's unable to pull away and move the fluid away from your lungs. So it gets fluid built up near your lungs and you have a cough. Some people will have retention of fluids in their legs and in their ankles called edema. Many people will feel fatigued and tired because they're just not getting enough oxygen to all of the organs and cells of their body. And then oftentimes people will have either a rapid heartbeat or an irregular heartbeat. And the reason their heart beats faster is because if with every heartbeat, less blood is getting pumped out to the tissues and organs, your body compensates by beating faster. So each pump doesn't pump as much blood out, but if you pump faster, you're still going to compensate for that amount. So another sign is that people will sometimes have an increased heart rate, and sometimes they might have conduction disturbances and atrial fibrillation. But these are some of the common signs and symptoms of heart failure in general, and they're the same signs and symptoms of cardiac amyloidosis. Now, the one thing that is different about cardiac amyloidosis than some of the other causes of heart failure is that because this is a systemic disease, these proteins circulate in your blood all around to all the organs. They usually affect other organs as well. So even though the heart might be the main issue, the main problem that somebody might be experiencing, oftentimes they will have other parts of the body that are affected. And the ones shown here are the ones that are actually very common with cardiac amyloidosis. So 90% of all transthyretin is produced in the liver. However, there is a small percentage of transthyretin that is produced in the retina of the eye. So some people can have ocular issues, including glaucoma or different irregular shapes of their pupil. Sorry. Pardon me. The other really impacted system is the nervous system, which I mentioned earlier, where many people will get amyloid in their peripheral nerves. So they will experience weakness and numbness and tingling and pain in maybe their feet, their toes, their hands. Sorry. My apologies. But a common other organ that is affected is the nervous system. And oftentimes this disease is actually diagnosed by neurologists instead of cardiologists. It kind of depends, number one, on the main organ affected, and number two, if you're in an endemic region that might have a lot of hereditary disease where neuropathy is the main manifestation. Other organs that could be affected are your gastrointestinal tract. Some people have constipation, some people have diarrhea, some alternate between both. And then some are just other organs in general. One of the main signs of wild type in particular is having a history of bilateral carpal tunnel syndrome. It's incredibly common for people to have wild type disease and realize that 5-10 years earlier they also had gotten carpal tunnel surgery. Of course, carpal tunnel is very, very common in general, so it certainly doesn't mean everybody with carpal tunnel has cardiac amyloid. It is just there is a very strong correlation between people that have wild type and have previously had carpal tunnel release. So not to go into all of these body parts, but one of the clues that should be noticed by physicians, but should be noticed by patients is, are there other systems that are in fact affected by this? And could these offer clues to the actual diagnosis? And so when we educate physicians and cardiologists and neurologists about this disease, we really emphasize the fact that it is systemic, that this needs to be looked at holistically for the whole patient, and that more than often than not, they will have other signs and symptoms of amyloid. And all of this needs to be treated, and typically by a whole team of specialists that can help the patient. So I'll move to the next slide. This is just a little bit more about the differences between wild type and hereditary forms. And the reason we explain this a little bit more in detail is because the hereditary form can have a slightly worse prognosis than the wild type. And because the different mutations that you can see with the hereditary form, there might have slightly different presentations. As I mentioned, the neurologic presentation. So if you think about the wild type, there's no mutation. It's associated with aging. More often than not, people with wild type will have had a history of carpal tunnel, maybe lumbar spinal stenosis, or a biceps tendon rupture. And previously, back in the days, this used to be called senile systemic amyloidosis because it was so associated with older age. It's not a great name. Senile systemic amyloidosis is no longer used anymore in general. But if you ever do hear that, some people may still say SSA, senile systemic. It is the same thing as wild type. And this is a disease that predominantly does not manifest until 60, 70, 80 years old. It can develop earlier, but it's extremely rare. And the vast majority of cases do not present until in their 70s or even 80s. Now that's slightly different from the hereditary forms, which can present slightly younger in their 60s and 70s. This is, as I mentioned previously, due to a mutation in the transthyretin gene. And even though transthyretin is actually a very small protein, it is only 127 amino acids. Researchers have identified at least 120 different mutations in this gene. For some reason, this gene is really prone to mutations. Now, an individual patient would usually just have one mutation. They don't have 120, but different mutations have been identified. They've been studied, and we try to understand a little bit more about how those mutations affect the patients, their outcomes, their survival, and their family members. And so some of the mutations can only affect the heart. For some reason, all they do is deposit amyloid in the heart. Some of the mutations will only affect the nerves. And then most of them actually have what we call a mixed phenotype, where what we talked about just a few minutes ago, multiple organs are involved. They might have some neuropathy, they might have cardiomyopathy, they might have some eye issues. I would say the majority of mutations are a little bit of a mix of each. And on this next slide, it's just a demonstration of kind of what we call the spectrum of disease. So on one end of the spectrum, you have certain genetic mutations that really only develop neurologic symptoms. And the most common one, and this is actually probably the most common mutation in the world, is what we call V30M. And all that means is that there is a valine amino acid at the 30th amino acid in the gene that is now mutated to a methionine. You don't really have to know too much about it other than V30M is very, very common. It's associated mainly with neurologic, but it can have some cardiac manifestations. And on the other end of this spectrum, there are some mutations that are only associated with cardiac. And the most common mutation that we see for the cardiac outside of wild type, which is not a mutation, is the V122I. That is valine, which is an amino acid, at the 122nd position that is now mutated to an isoleucine. So it just lets you know that some of these mutations, we can now understand a little bit about maybe the natural history of the disease, the onset of age of the disease, the prevalence in families, and it's important to know if you have the hereditary type or not. The one last thing about the V122I mutation is that there's been many studies that show African Americans have the highest incidence of the V122I as a gene carrier. So we really try to make sure that physicians are aware to be looking for this, especially if they have an African American patient that has some of these signs and symptoms that is so common to cardiac amyloidosis. So if I go to the next slide, when we started learning more about this disease, and I will tell you, this disease has been something over the last 10 years that went from incredibly low awareness and knowledge, no therapies except for heart or liver transplant, and very few experts in the field, to now, thankfully, and a time where we have a lot of physicians that know about this disease, are much better at diagnosing it and following family members and patients to try to get them the right treatment. And thankfully, there is not only some treatments on the market, there's many, many that are being developed for this disease that hopefully will be on the market very soon. So this group of experts that have been studying this disease for a very long time have also been aware of what we call asymptomatic gene carriers. So if a patient has the hereditary form of the disease, they obviously carry the gene. Their family members, children, brothers and sisters, may also have the gene. And if they are tested and they don't have any symptoms, they don't have the disease, but they do have the genetic mutation, there is a list of recommendations as to what physicians and patients should do in order to follow that asymptomatic gene carrier so that they can identify at the earliest possible time if somebody starts to develop the disease of amyloidosis. Truthfully, even when some people do have the gene, they never develop the disease. That's not always the case by any means, but there are some cases where people just don't seem to develop it, even if they have the mutation. However, it's important if you know you have the mutation and you want to be followed very closely, these are the recommendations for yearly monitoring, looking at your conduction system with ECG, looking for biomarkers that suggest there might be some damage to the heart, you doing an echocardiogram, which is basically an ultrasound. If you think about maybe a pregnant mother where they do an ultrasound of the baby, this is an ultrasound of your heart. So they look at the structure and the function of the heart. Non-invasive, not painful, just imaging. And then of course, checking on the nerves, checking on the eyes, and doing some further tests maybe every 2 to 3 years. So this we try to educate on, because if somebody does have, maybe they're young and they just haven't reached the age where they might develop signs and symptoms, it is highly recommended to monitor those patients, or those people, I should say, because the earlier you can identify that you have this disease and get treated, the absolutely better people do. There is no doubt about that. The earliest you can treat, the better patients do. So if you are a family member, if you have family members, you should hopefully be trying to be monitored through your physicians and watching for any signs and symptoms. The other thing on this page is just to really think about genetic counseling, and your physicians can also refer you to them, who are a great resource about hereditary diseases and what to expect. I just want to check the time. We're doing okay. All right, so diagnosis of this disease. I mentioned that up until the last few years, this disease has really been elusive to a lot of patients and physicians, because there's a lot of reasons, and there's reasons shown here. Basically, physicians were taught that this was a very, very rare disease, and it is. I mean, look, this is still a rare disease, so I don't want to alarm anybody. However, it isn't as rare as I think we thought it was previously. So there was kind of fragmented knowledge about the disease. They didn't know how to diagnose it necessarily. There wasn't any treatments available, really, other than a very challenging either heart or liver transplant. There was only one way to definitively diagnose this, and this was taking a tissue biopsy. And if we're talking about cardiac amyloidosis, oftentimes that meant people had to have a catheter into their heart and take pieces of tissue from your heart. Obviously, that has some risk related to it, and not every physician would like to, take that risk, and or patients. So doing an invasive biopsy was also kind of inhibitory to finding this exact diagnosis. And the signs and symptoms, like I said, are very broad, they're very general, and they don't necessarily immediately suggest cardiac amyloidosis. So this has been a very misdiagnosed, a very underdiagnosed disease, and unfortunately for many patients, not getting the treatment that they should have had they gotten the correct diagnosis. So there are things that physicians and hopefully patients can do to help raise the suspicion of this disease. And the most important thing about getting the accurate diagnosis is just having a suspicion. Unfortunately, most physicians don't even suspect it. So you cannot diagnose something if it's not even in your mind. So raising the suspicion of this disease has been what many researchers, not only at Pfizer, different companies, academic medical centers, have really been trying to do over the last 5 to 10 years, is to educate about what the signs and symptoms of this disease are. And there's certain tests that can help raise the suspicion. When we're talking about the heart and possibly a cardiologist, they should be doing an echocardiogram, which is the ultrasound that can tell the physician if the heart is thick, if the walls of the heart are thick, if the ejection fraction is normal. There's some red flags and signs that are suggestive of cardiac amyloid, but not diagnostic. You cannot diagnose this disease with any of these tests. It is these tests help a physician to suspect that possibly this is the cause of the heart failure. The electrocardiogram measures the conduction of the heart. So the pacemaker sort of function of the heart, telling the heart when to beat and when to beat properly. There are definitely some clues to what the electrocardiogram look like that suggest cardiac amyloid. There's some people might have an MRI or a CMR, which is basically a cardiac MRI, where they're looking at your heart. This is great if you can get an MRI because it really gives the physician a lot of information about the structure and the function of the heart. But it's also not diagnostic. It just tells the physician that this looks like it could be amyloid. Maybe I should do some further tests. And then again, measuring the cardiac biomarkers that when your heart is under stress, when there's any toxicity, it will secrete these biomarkers. And if they're elevated in your blood, it tells the physician, something might be going on with their heart. I need to do further tests. The other non-cardiac signs and symptoms and tests that can be done are looking at the nerves. So oftentimes, at least in the centers of excellence that are amyloid experts, they bring in an entire team of specialists. They use cardiologists, neurologists, gastroenterologists, hematologists, because all of them contribute to understanding about what's going on with this patient. So doing a neurologic exam is not always what a cardiologist wants to do, right? They're not neurologists, but they can pull in other groups in their hospitals or clinics to evaluate the person's neurologic function. Doctors for the eye, gastrointestinal doctors, looking at patient and family history is usually can be a very good clue if there's a history of heart failure. However, of note, when we first started really researching this disease, half of the people that had the hereditary disease said they had no family history. And we don't know why exactly, but they don't know their family history, or maybe the family member passed away, or they just never knew what was wrong. So not having a family history is not always a negative thing, because many people they don't even actually know that there is a family history in their family unless it's really obvious. So these are some of the tests that can suggest and raise suspicion of the disease. But in order to actually definitely diagnose the disease, there are two different tests that can be done. Thankfully, nowadays, there is a non-invasive, basically not painful imaging test called scintigraphy. Bone scintigraphy is not really new. They used to use it in oncology for prostate cancer patients to see if there was any bone metastases associated with the patient. But that same technology can now be used to inject a very, very small amount of a radioisotope tracer into the patient. They wait a couple of hours, and then they have a scan, like a CAT scan, an imaging scan, where they look at the heart. And if the heart has taken up that tracer and it lights up on the camera, then this could be transthyretin cardiac amyloidosis. And I say could be because the only way you can definitively determine that it's TTR is to also test for light chain, that other cause of cardiac amyloidosis. The scintigraphy test is 100% accurate if the heart lights up to a certain degree and the light chain test is negative. What we are finding out, though, is some physicians are only doing the scintigraphy test and not doing the light chain. And that is an area that we really, really, really need to help our physicians and patients know, that you have to do both in order to have a definitive diagnosis. If you cannot determine 100% by the scintigraphy, some patients will still need to go on to a biopsy. And that biopsy can be of the heart. Sometimes it can be of other tissues, especially if they have other organs involved. Some people might have a lot of neuropathy, and you can do a nerve biopsy if you don't want to do a heart biopsy, and they can test amyloid in that tissue and type it and determine if it's light chain or if it's TTR. So most people can just have the non-invasive bone scintigraphy test and the light chain. But if that doesn't tell the doctors, if it's not definitive enough, some people might have to have a biopsy. But these are the two tests that are the only way to definitively say, yes, you have TTR cardiomyopathy or you have light chain cardiomyopathy. And if you do have a diagnosis of TTR cardiomyopathy, similar to following the asymptomatic family members, there are tests that your physician will do every 6 to 12 months. Obviously, they will determine for you what the appropriate therapy might be. Hopefully, they will be able to put you on the appropriate therapy and then follow you to see how you're doing. If you're stabilizing, if you're progressing, if you're getting better. But the tests that you would expect would be tests like we talked about earlier, where they're looking at your heart, they're looking at your conduction system, they're going to follow your nerves as well. They're going to ask you questions about quality of life, maybe see how far you can walk in 6 minutes. It's called the 6-minute walk distance or test, because that kind of tells them how well your heart is functioning. And then every 12 months, they might do additional tests. But as I've mentioned, oftentimes people will be followed by more than just one doctor because of the need to really look at your eyes, your nerves, your heart. So ideally, it's a very holistic approach, along with your caregivers, patient advocacy groups, genetic counselors. There is a huge amount of resources for patients with this disease. And if you are not aware of it, please let us know, because between Mended Hearts and Oliver and I, we know, and it's not through Pfizer, it's through other parties. So if you have questions and you don't have any resources, there is a lot out there. And I think this is my last slide. It is really just the importance of collaboration. Collaboration between the patient, collaboration between their physician, collaboration between all of the different specialists that will likely need to be involved in the care of the patient, and having a network, whether it's a patient advocacy group, your physician, genetic counselors, etc., is so helpful. So let me see. I think in summary, I would just leave you with a few thoughts. There are two main causes of cardiac amyloidosis. Main causes, not the only, but the very main. It is light chain amyloid and TTR amyloid. In order to diagnose this disease, the most important thing is for your physician to even be aware of it and have a suspicion. And the only way they will really get those suspicious clues is to do things like an EKG, an echo, look at biomarkers, maybe bring in a multidisciplinary team. You can be diagnosed non-invasively, which is wonderful, because previously we did not have that option. And because this disease is a progressive disease, it's really important to identify early. It's really important, if you can, get treated early and get all of the resources that you can, because there's a lot out there for you. I'm going to pass it over to Oliver, and hopefully we'll have some time for questions. But Pfizer has a really important study option for patients that I think Oliver wants to share. So thank you so much, everyone.
Thank you, Jennifer, so much for providing that wonderful background on cardiac amyloidosis. Let me see if I can advance the slide here. And I'm excited to be with you today to present our study at Pfizer, the ATTR POP study. It's the global prevalence of ATTR-CM, or cardiac cardiomyopathy, in participants with heart failure with preserved ejection fraction, which are commonly referred to as HFpEF. So Jennifer laid out really the importance of understanding ATTR-CM and it being diagnosed. And there are three important aspects to this study, which I'll just sort of highlight. One of which is that ATTR-CM might be underdiagnosed, and for many of the reasons that Jennifer mentioned earlier. In addition, the advancement in cardiac scintigraphy has really changed how ATTR-CM is diagnosed. This non-invasive image, in addition to some of the clinical and lab testing, like Jennifer mentioned with the light chain, can remove the need for cardiac biopsy in most cases to diagnose ATTR-CM. And probably one of the most important aspects is the early identification and diagnosis of ATTR-CM, which can provide available treatments that can prevent and or delay the worsening of the disease. So our ATTR POP study is also known as B346-1087. The primary objective of the study is to assess how common ATTR-CM is among participants with HFpEF within a clinically at-risk population. And our secondary objective is to assess how different or how common ATTR-CM is among participants with HFpEF at the country, regional, and global level. As an exploratory objective, we will assess the correlation of the clinical status and medical history with scintigraphy and disease status for participants with ATTR-CM. For our study design, this is a global multi-center study. We're looking to enroll approximately 2,000 participants with heart failure and preserved ejection fraction. And the study will consist of 3 or 4 study visits. And I mentioned the 3 or 4 because we were able to combine our screening visit with our study visit 1 to make it more feasible for patients as well as physicians involved in the study. So participants with HFpEF will be invited to participate in this study. And during the screening procedure, they'll be provided with informed consent and undergo echocardiography. And if they have already undergone an echocardiography within 6 months, they won't need to undergo it again. And after obtaining a medical history and some other measures, they can go on to study visit 1, where current medications will be recorded and scintigraphy will be performed. In addition, we'll obtain blood and urine samples, as well as additional data like the 6-minute walk test that Jennifer mentioned. There will be 2 additional visits conducted as remote visits. The follow-up visit 1 will occur approximately 2 weeks after study visit 1. The participants will be informed of their ATTR-CM diagnosis, and then if necessary, a follow-up visit 2 will occur 6 months later, where participants will be assessed based upon their scintigraphy grading, which I'll discuss in just a few slides. So if you're grade 1 or higher, they'll just be assessed for current medications and vital status. But if patients have a grade 1, they'll be asked whether they had further biopsy testing to confirm the presence of ATTR-CM. Key inclusion criteria for this study will be male and female, age greater than or equal to 60 years of age, with a history of heart failure, with at least 1 episode of clinical evidence of heart failure without a hospitalization that required treatment with a diuretic for improvement, or 1 prior hospitalization for heart failure. In addition, left ventricular ejection fraction measured by echocardiography greater than 40%, and end diastolic interventricular septal wall thickness greater than or equal to 12 millimeters. And again, this is determined by echocardiography. In addition, participants will be need to be willing and able to undergo the scintigraphy. Key exclusion criteria for the study include diagnosis of heart failure with reduced ejection fraction. So this is less than or equal to 40%. A prior clinical history of a heart attack, cabbage, multivessel obstructive coronary artery disease, greater than 50% stenosis of more than or equal to 2 epicardial coronary arteries, the presence or history of any severe heart valve disease, and any confirmed diagnosis of cardiac sarcoidosis, hemochromatosis, muscular dystrophies, cardiomyopathy with reversible causes or known genetic causes, or known pericardial constriction, and any type of diagnosed amyloidosis or prior diagnosis of ATTR-CM. Jennifer mentioned the scintigraphy being utilized as a non-invasive method to assess ATTR-CM. So all patients will undergo cardiac scintigraphy at visit 1. And this is, again, a diagnostic tool for ATTR-CM. And it's similar to an MRI machine, as you can see from the top right of this slide. And you'll be injected with a small amount of safe radioactive labeled tracer. And after a few hours, you'll be able to be imaged. And the grading can stem from grade 0 to grade 3. Grade 0 would mean that you're negative as a diagnosis for ATTR-CM, and grade 1 sort of stands for it might be positive, but you'll need a further testing, oftentimes a cardiac biopsy to confirm the presence of ATTR-CM. And then grades 2 and 3 confirm a positive diagnosis for ATTR-CM. There's approximately 30 sites participating in 7 countries, including the United States, Spain, France, Italy, Japan, Germany, and the UK. There's 10 sites in the US, and currently additional sites are being identified. Some of the current US site locations are located below, and there's a link to find out more information about the ATTR-POP study on this slide as well. I want to thank you all for your time, and thank you to Mended Hearts for the opportunity to present our study to you today. Thank you.
Thank you so much. What amazing information. We do have some questions, and so I'd like to just start. Maybe I will just read the question, and then whichever one of you thinks that you can answer it the best, maybe you can take the lead on that. The first question I think would probably be for you, Dr. Schumacher, I'm sorry. It says it sounds similar to symptoms of system sarcoidosis. Is there a correlation? Oh, you're muted.
All right, can you hear me now?
Yeah.
Okay, great. Yeah, so it's very interesting. You're correct. These are very similar in some aspects, meaning there is something. In the case of systemic sarcoidosis, I think it's granulomas, and it's an inflammatory disease that has granulomas, and that gets into the heart. So it's very similar that there is something going wrong in the body, something builds up in the heart, and then people get heart failure. They're not related in the sense that it's a different protein and there's completely different therapies. So yes, to a certain extent, there's a lot of similarities there, and probably the symptoms that people have are very similar, but the mechanism, the proteins involved in the treatments are very different. So you would want to make sure, you would definitely want to make sure if it's sarcoidosis versus cardiac amyloidosis.
Great, thank you. Along the same line, is there any correlation between the thyroid and this diagnosis?
The thyroid and what?
The ATTR-CM.
Oh, I see. No, we have not found any correlation. What's interesting about transthyretin is even though it is a carrier of the thyroid hormones, there is a redundant pathway, meaning there's other proteins that also carry these thyroid hormones. And not only in studies where they've completely knocked out the transthyretin gene in mice, as well as the protein in humans, we can apparently do without transthyretin. So we're not 100% sure that for a lifetime of not having this protein is okay, but we know that people that are taking therapies that knock out the transthyretin, which theoretically, would have an impact on thyroid hormones and even retin A and vitamin A, don't seem to have an impact. So we have not identified any causes related to thyroid or any effects of knocking out the transthyretin gene. And most of the therapies, we don't see any issues with the thyroid. So I'm not aware of any cause and effect. It's more related to the liver, the transthyretin protein itself, and then whatever organs that the amyloid might deposit in, which oddly enough is not the thyroid.
Great. So this question is probably for you, Dr. Glass. What if you have an ICD that is not MRI compatible and you couldn't have that scintigraphy? I'm sorry. So does that mean they're excluded from the study?
Yeah, scintigraphy is really a critical element to the study just because of its non-invasive, ability to diagnose ATTR-CM. So that would not allow to participate in this study.
Okay. And a question that I know probably a lot of people are asking: if you're diagnosed with ATTR-CM, are there different treatments than if you were just diagnosed with HFpEF?
Yes.
Okay.
Definitely, yes. So HFpEF is really HFpEF isn't even it's really not a disease. It's a description of the heart failure. It says you have heart failure, and the amount of blood that you're ejecting with each beat is normal, preserved. So that's what heart failure with preserved ejection fraction means. But the treatment for HFpEF, it's really, you need to know what the underlying cause of the heart failure is to diagnose it. Now, many physicians globally, US, they will just say you have heart failure, and then they treat you with diuretics and calcium channel blockers, and they don't really get to the bottom underlying cause of it. And sometimes that's fine. Sometimes people do really well on treatments that are really just symptomatic, not cardiac amyloid patients. They do not do well with that. And you really do need to identify what the cause of that heart failure is in order to treat that. But they are very different. If you have HFpEF and you get treated with some of these very common heart failure medicines, and you don't feel better, and maybe you even feel worse, that's also a really big sign that it is something else for sure, but it could be cardiac amyloid, because we know these patients with cardiac amyloidosis actually do not do well on some of the calcium channel blockers and beta blockers, because it takes that compensation of that increased heart rate away, and then people feel even worse. So one of the red flags that we always talk to doctors about is, are the patients doing well on their heart failure medicine? And if not, that's a sign that this could be cardiac amyloidosis. But they are very different, and you really would like to, if you can, understand what the underlying cause of heart failure is.
Great. And then there was another question in the chat that asked what medicine is used in treating this disease. So are there specific medications for ATTR-CM?
There is. So, just disclaimer, we work for Pfizer, and we're not here to promote any drugs or anything. However, at least in the, globally, nowhere in the world is there anything that is approved for ATTR cardiomyopathy other than Pfizer's drug called Vyndaqel or Vyndamax. Now, there are drugs that are approved for the polyneuropathy, the neuropathy of the disease, and they are, there's a number of them, Onpattro and inotersen, but those are usually described by neurologists because they're indicated and they were studied in patients to look at their nerves and their neuropathy. However, there are many, many drugs right now that are very, very close to finalizing their clinical research, and that will more than likely be on the market in addition to Vyndaqel very shortly. There's clinical trials that patients can go on, and if they wanted to do an experimental therapy. But yes, currently, right now, there is literally, and then I should say a heart transplant or a liver transplant, which I know is not necessarily, a great option for most people, but between liver transplant and Vyndaqel, those are the only therapies right now, and more coming.
Great. And I think the final question here is, before we leave, we're 1 minute over, I'm sorry. It says that some doctors are resistant to follow-up test results from other doctors, especially if they're tests they didn't ask for. So I think that, what would you say to a patient who's not experiencing relief, want more testings? Are we looking second opinion? What's your opinion?
Yeah, and that's actually been unfortunately the experience of so many people with this disease, is because the physicians, many of them don't really know what this is, so they kind of cycle. The patients either will give up, which is terrible because they're tired of going to different doctors and trying to figure out what's going on, or they get the wrong treatments. Some people, and I think I saw it in this chat, some people got treated for light chain, which is a chemotherapy, and they actually had TTR. And so it's not only just getting the wrong therapy, you're actually getting, like a cancer-related chemotherapy that can make you very sick. So that's why it's so important to really make sure you know what the disease is. But patient persistence and education and resources on the website, and don't just accept what your doctor says. And I tell you that just because I know so many doctors that just didn't realize they didn't know this disease, not out of trying to do the wrong thing, they just didn't know. So if you're not feeling well and you have a suspicion that maybe this isn't the correct diagnosis, keep asking, and maybe, definitely a second opinion. So
Great. Well, thank you both so very much for joining us today. It was very informative. Thank you all who joined us today. I hope that you learned a lot, as we did, and we will have the information available on our website shortly. So thank you all very much and have a great day.
thank you, everyone.